Good afternoon, my dear colleagues in Bangladesh and beyond Bangladesh. Today, I'll be talking about the role of radiotherapy to the prostate in a setting of metastatic prostate cancer, mainly to the bone. What would be the indications, which patients will benefit from such local radiotherapy, and when to consider such radiotherapy and what to irradiate. So I'll try to answer this question whether adding radiotherapy to prostate in patients with bone metastasis will improve any overall survival or disease-free survival. And if it is so, when to consider radiotherapy? What is the best time for that? What evidence we have to consider radiotherapy regarding the time, and what would be the dose? And what should we irradiate? Should we irradiate only the prostate or the lymph nodes if they are negative lymph nodes in the pelvis? And the timing, what would be the best time to start? And what about the other bone mets in this setting? Should we really target them by SBRT or conventional, or just leave them for systematic disease? Now, we know from the evidence-based medicine that radical local treatment have been tested in many cancers, like in the RCC, small cell lung cancer and breast, and proved the efficacy. So why not in prostate cancer? Now, before going to this discussion, we should keep in mind that bone metastasis, it could be a wide bone metastasis or just only few spots of the bone metastasis. But in both cases, it is M1 bone mets, but keep in mind whether it is a low or high volume metastasis, because that has to do in the prognosis of the disease and the outcome. Now, two important studies try to answer this question. The Herald trial, which is a multi-center randomized controlled trial, recruiting 432 patients with a metastatic prostate cancer to bone with a PSA more than 20. And the period started from 2004 till 2014 and reported in 2019 in the European Urology, the effect of survival of the ADT or adding radiotherapy to the ADT in patients with primary bone metastasis. So I will share with you the results of this important study. You can see here that about 216 patients of both arms were included. And this is the ADT, the patients and the tumor characteristic, the patient's characteristics of the adding radio or without adding radio to the ADT, and with the definition of the low volume being less than 5 lesions in the bone, which is important. About 41% of patients had less than 5 lesions, and the other group 5 to 15 lesions, and about 25% of patients had 5 to 15, the rest of them more than 15. Now, on the right side, you can see in the slides that many patients also received systematic treatment as well, between 10 or to 12 months to 30 months with these two arms. Now, looking at the results of this, it showed in the left side that you can see here that the for the disease progression or PSA progression disease, it was statistically significant in favor of adding local radiotherapy to the ADT. You can see it here, the p-value less than 0.2 or 0.2. And but on the right side, the overall survival did not change. So we know that for the PSA progression, it really there is a benefit for that. And if you look at the multivariant, you can see that it favors the radiotherapy, adding radiotherapy to the prostate while considering the systemic or the ADT. And the most important factor was the number of metastases. And this is really good to keep in mind, that patient will do very good if they have metastases less than 5 lesions, comparing with the 5 to 15 lesions. So the Herald study also tried to answer the question that in practice, when to start the hormonal therapy, and actually the timing, which was allowed in this study within 3 months. So if we start the local radiotherapy to the prostate within 3 months. So depending upon this study, so there is a scientific basis behind it. And the dose, actually two doses were allowed, either 70 and 35, 7 weeks, that is a conventional way, or other options also added, whether to consider hypofractionation, considering 57.719 fraction, 3 times a week for 6 weeks. Although now mostly it is the 60 and 20 fraction, hypofractionation is the mostly used one. Now in this, the IMRT was preferred over the 3D, although the 3D conformal radiotherapy was allowed in this study. And this is also important, what to include in the radiotherapy field. It is the CTV would be the prostate with any extracapsular extension or base of the seminal vesicle, with the BTV 1 cm if you are using 3D, 8 millimeter if you are using IGRT, IMRT, or VMAT. And here, no pelvic lymph nodes radiotherapy was considered. So this is really important, that what you have to irradiate in case where you have a negative lymph nodes in the pelvis, it is only the prostate or some extension if it is above that to extracapsular or seminal vesicle, but don't routinely irradiate the lymph nodes. And also you try to utilize the IMRT or the VMAT rather than the 3D if possible. And again, the time to consider is within 3 months from initiation of the ADT, and these are the doses that have been used. So this is, and you can see on the right side about the difference in the IMRT and the 3D, where the conformality more in the IMRT, and hence the side effects will be less. So radiotherapy, another study beside the Herald study trying to answer this question is the this study, the Stampede study, that radiotherapy to primary tumor for newly diagnosed metastatic prostate cancer, and randomized phase 3 trial. Again, a very good number, about 1,000 in each arm were used. With metastatic burden, it was here defined as low or the high. And most of these patients, they had a bone metastasis. About 90% of patients in both arms had bone metastasis, although some had liver or bone or lymph node or lung or lymph nodes, but the bulk of patients had a bone metastasis. Now, again, the timing of this, it was like roughly 3 to 4 months. So that's why the practice now that within 3 months, the first 3 months, according to these two trials, the Herald and the Stampede, that you can start local radiotherapy to the prostate. And when docetaxel was used, so it was kept like 3 or 4 weeks between the chemotherapy and to start the radiotherapy. And the dose here also is important, that it used 36 and 6, weekly 6 gray for 6 weeks, half of the patient roughly, and the other half 55 in 20 over 4 weeks. And as I said, mostly now the most practice that to use 60 and 20 hypofractionation over 4 weeks, more convenient to the patient rather than 7 or 8 weeks. Almost 99% of patients received the LHRH analog. Now, in the Stampede, the IMRT and VMAT were preferred. And you know, the IMRT and VMAT, now these are the high technology that we can concentrate radiotherapy to the prostate. Will conformality is really very good, with less side effects to the rectum and the bladder. And we just published actually an article comparing 10 cases of VMAT and IMRT, where in the British Journal of Radiology just 2 weeks ago, where we proved that probably the conformality, the VMAT is a little bit better than IMRT, and the dose to rectum and bladder is also less. So, but still, IMRT and VMAT, they are very good to be considered for those patients. Again, no lymph nodes was, lymph nodes were irradiated in this, and the CTV and the BTV, like the Herald study, was just to the prostate with any extension to the extracapsular. So there is no need routinely to irradiate the lymph nodes if they are negative. Now, the results of this, again, for the overall survival for this was the, in general, for all cohort of patients, it was the same, no statistically significant difference, but the disease or failure-free survival was in favor of patients who received local radiotherapy to the prostate beside the ADT and other systemic therapy. And if you want to see now the high volume and low volume, there was an overall survival and disease-free survival benefit with a statistically significant p-value for the low, but it wasn't for the high. So now we know that patients with the low volume of bone metastasis, not only the disease-free survival, but probably the overall survival benefit will be there when you consider local radiotherapy to the prostate, and you can see it from this multivariate study. So the other question, since we know now the duration of or the dose of radiotherapy, what to irradiate and when to irradiate, and who will benefit from local radiotherapy to the prostate. Now the other question is, should also we treat bone lesions in low volume? If you have like 2 or 3 or less than 5 bone lesions, beside the systemic therapy or ADT plus minus systemic therapy and local radiotherapy to prostate, should you go for the SBRT or conventional other words, should we go for curative intent for those patients? This actually was discussed as no study to answer this question. It was discussed and published in the meeting, consensus meeting in 2019, and it was published, Management of Patients with Advanced Prostate Cancer, report of the Advanced Prostate Cancer Consensus conference in 2019, and I was really delighted to be among this discussion in Switzerland meeting 2019. And the question for the 72 cancer physicians or experts in prostate cancer, this question, 10 controversial areas or question were put in front of these physicians or the prostate experts to try to answer and to see the consensus. Because, you know, no clear evidence to support, no clinical trials to support these, to answer this question. So number one, towards the primary, management of primary tumor in metastatic setting, and should pelvic lymph nodes be irradiated if positive? Now we know in the 2 Herald and Stampede, if it's negative, there is no need. But what about if you have a positive lymph nodes in the pelvis? Should also go and treat the pelvic lymph nodes, the prostate, beside the ADT and the plus minus systemic therapy. And this is the consensus of the experts, that to answer the first question, management of primary tumors in the metastatic setting, based on the current literature, local treatment of primary tumor has an overall survival benefit. It's a strong consensus in about 98% for an overall survival benefit for local treatment of primary tumor in patients with low volume and low burden of M1. So it increases overall survival and disease-free survival and should be standard of care. But the exploration from the data from the Stampede that you should not go and try to do surgery now as a standard of care instead of radiotherapy. We have evidence for radiotherapy effect, but we do not have as a local treatment of surgery. So we should not jump to consider surgery. And this was the consensus of 88% of the experts, not to really to consider surgery at this point. The other question that was answered here, in case of RT of the primary tumor in patients in newly diagnosed low volume of burden M1 castrate naive patients who have a clinical N1, if you have an N1, if you have a pelvic lymph nodes, do you recommend to irradiate the lymph nodes or not? 75% of the cancer experts, they voted for yes, you treat the pelvic lymph nodes and the prostate, while the other 25, they said that there is no evidence, clear evidence of doing that. So probably in some cases where you have a lymph nodes, you may also target the lymph nodes as well. Now, the other question, again, there was no consensus that what about the other lymph nodes, especially for the low volume? Should you go for each and every one and treat by SBRT or conventional radiotherapy? And when this question was thrown to the expert, 18% of the panelists voted for that this might prolong the disease-free survival, while 14% voted for prolongation of overall survival, 12% voted for delaying the start. Probably if we consider SPRT or conventional to the bone mets, we may delay considering the ADT. And also 37% voted for all the above three, that it might delay of the ADT, prolong overall survival, and also it may prolong the disease-free survival. So as you can see here, there is no consensus about this. What is the best way to consider? So you have to look into many things, the patient-related issues and also the tumor related issue to consider the palliative. Although in my practice, we do consider SPRT for less than 5 or 4 lymph nodes, what we call like a curative intent. Now, there are ongoing studies trying to answer this question. The VIS1 trial, which is this will test the adding the AB for prostate and also the radiotherapy to the prostate, arm 1 ADT with docetaxel, arm B ADT docetaxel with AB, and arm 4 or C, it is ADT docetaxel and radiotherapy, and D ADT with docetaxel with AB and with local radiotherapy to the prostate. And we have to wait the results for this study. There are other 2 studies are ongoing now at MD Anderson, a study for systemic therapy or systemic therapy plus radio or surgery. Now they are considering as a local therapy, not only radio, probably to think about surgery as well. Although standard of care now not to consider surgery unless we see the results of this study. But probably the local radiotherapy should be considered. Now, another SWAG study is systemic, also testing the systemic therapy versus systemic therapy with RT or surgeries like the MD Anderson study, and we have to wait the study, the results of these studies. 2 another Canadian studies are trying to test this, the standard systemic therapy with or without SPRT to the oligometastasis. Now, this will answer the question, should we consider SPRT for all lesions less than 5 while irradiating the prostate locally in patients with bone metastasis? And the other study using the ENZA with or without SPRT to recurrent oligometastasis for 5 or less. So it's really the diagnostic treatment decision should always be individualized and with the MDT discussion based on patient specific and also tumor specific, take into consideration the disease extent, location of the metastasis, comorbidities, treatment preferences, current and emerging clinical evidence, and also logistic and economic burden of this. So to conclude, radiotherapy to the prostate in low volume bone metastasis less than 5 improves the overall survival and disease-free survival, and in my opinion, should be considered as standard of care we should prefer to give. The usual practical dose now is used 16-20 using the hypofractionation, although 70 or 75 or 76 in the conventional can be used if hypofractionation is not used or there is no experience with it. Timing, now 2 studies show that probably within the 3 months, the first 3 months after ADT, you should start of radiotherapy to the prostate. Ongoing now studies to define the role of SPRT to the oligometastasis and adding systemic treatment to the hormone therapy and radiotherapy to prostate. And as always, we say that all these patients, especially the prostate cancer, should be discussed and the decision should be taken in a multidisciplinary clinic. By this, I finish my talk. Thank you so much.